Okay. Hmm. Maybe we can start with what is pharyngitis. Um, so Krishna, if you were to take a crack at what pharyngitis means, how do you store it in your mind?
I would just go by the
Yeah.
etymology of the word itself, pharynx
Yeah.
and itis.
Yeah.
So inflammation of the pharynx.
Yeah.
I'm from my ENT lectures in third year. I do remember that there's acute and chronic forms, and
Yes.
that it's not always very obvious to differentiate between the two. But acute is usually a very sick patient who has
Mhm.
fever and is very red with respect to
Right.
the examination of their throat and things like that. And
Yeah. Right.
chronic is probably someone who has a more um, it has longer duration of symptoms in terms of hoarseness, cough,
Right. Right.
postnasal drip, etc.
Yeah.
And yeah, I mean that's how else do
Yeah.
I start talking about
Yeah, no, I think
pharyngitis?
that fundamentally you're saying that it's essentially bilateral inflammation of the pharynx, and I think that's a very wise place to anchor yourself. And I think that the presenting concern is predictable, right? It's a patient who says that their pharynx hurts, and otherwise colloquially translated as a sore throat. And you might ask yourself and sit with a moment about how quickly we often translate the word sore throat into pharyngitis. And I think that's a very wise leap. Uh, but it's important before we zoom in on pharyngitis to ask ourselves what else might masquerade under the label of a sore throat that is not pharyngitis. So, Saket, you might take a crack at that just based on experience or anatomy. What conditions do you think can masquerade as pharyngitis, but when you look, you see something else?
Hmm. So the patient is coming in with a complaint of
Sore throat.
sore throat,
Yeah, but it's not
but
pharyngitis.
all right. I mean, I can look at the other structures and see,
Yeah.
does he have enlargement of his tonsils? Is there like possibly something more sinister um,
Mhm.
a tonsillar, like peritonsillar abscess or a
Sure.
retropharyngeal abscess? Maybe something outside the throat itself that could be um, causing presenting with the sore throat.
Yeah.
Um, yeah,
Yeah.
I'm not sure.
I think you actually hit the nail on the theme, which is that pharyngitis is a diffuse inflammation of the pharynx. And I think that the thing that will fool you the most is a focal structural cause, that instead of having a diffuse process, you have a strategically focal process that's masquerading as a diffuse one. And I think the two most common examples, one of which is nearly universal, is ulcerations. And your problem, instead of being pharyngitis, becomes oral ulcers. Now, the difficulty in singling out that diagnosis is there's a lot of overlap between oral ulcerations and pharyngitis. So, as an example, sexually transmitted infections can cause either of them, but influenza, COVID, so on and so forth, don't cause oral ulcers unless you have the virus cause secondary abscess ulceration. So, by far and away, the most common surprise thing I see is I open the mouth, I see a large ulcer somewhere, and that's what's causing the irritation, not diffuse inflammation. I think more ominously, you see a mass, and that mass sometimes turns out to be a malignant mass or something else. But I think the premise of the visualization is to establish, do you see focality or do you just see diffuse rubor? Do you see cellulitis or do you see an abscess? And I think that distinction is really, really key. Most of the time, though, the patient's ability to use their tongue and very fine somatic motor perception in that very critical area allows them to give you a heads up. And they often say it hurts right here, or they give you cues that they've picked up on the focality. And so, how many times have I seen a mimicker of pharyngitis with sore throat? I'd say 1 in 10, like 10% of the time, the patient hasn't picked up on the vibe that there's focality, and the physical exam is necessary to do so. Most of the time, you translate pharyngitis, and in pharyngitis, you immediately translate it into something else. And that something else is driven by base rate. So, why don't we just study the base rate for a moment? So, Mohammed, if you are now confident that the problem is in fact a pharyngitis, and you have not yet seen the patient, what do you think the odds are of the diagnoses they will end up with, just statistically speaking?
Um, I will think about infection as the most common.
100%. Infections are by far and away the most common. To give a little bit of breathing room to non-infectious considerations for fun, because we will only give them 2 minutes of our time. Um, I think, um, yeah, I don't even know where to begin really with the non-infectious considerations. But I'm curious, Sarah, if you can think of anything that would tickle the CP solver's VMR fancy of non-infectious pharyngitis. What crosses your mind?
Yeah, I think aphthous ulcers can be like painful, like
Good.
in the case of like Crohn's or another
Beautiful. Yeah. Excellent.
inflammatory
Excellent.
condition.
Excellent. Yeah, so autoimmune, there's so many lupus, Crohn's. In the realm of cancer, you can get so many causes of pharyngitis from cancer, though odds are you're dealing with a pharyngitis mimic rather than pharyngitis itself. But sometimes you can actually get leukemic and lymphomatous infiltration of the pharynx, causing a diffuse inflammation on the surface. But when you biopsy that inflammation, it's not polyclonal cells, it's actually monoclonal population of cells. Drugs can do it, as Yusuf just mentioned, with granulocytosis, and endocrine diseases too. Uh, the overlap between endocrine diseases and pharyngitis usually involves medications. Um, yeah, so the truth is that when you have pharyngitis, you could be dealing with the tip of the iceberg and many systemic diseases affecting the pharynx. But as Mohammed said, it's infection, infection, infection 99% of the time. And even within infection, there's a profound base rate. So, Simi, if you were to make an educated guess about within infection, what kinds of infections tend to predominate? What thoughts cross your mind?
Maybe I think just seeing the cases presented recently, I think strep throat is something we can think
Mhm.
about, but also EBV and CMV,
Yeah.
and sometimes gonococcal infections. That's what I
Mhm.
can think about.
Yeah, you listed the second, third, and fourth most common. Number one looms large. And to number one, I think we got to go to Captain PCP of America. So, Austin, tell us, what have you seen hundreds of times over and over again?
Yeah, I think anytime someone comes in and says they have a sore throat, it's the question of which virus do they have and do we care about what virus do they have? And usually that's dictated by sort of like the time course and the patient's comorbidities. But statistically speaking, and someone comes in with acute pharyngitis or diffuse pain, then usually you're going to translate to that a virus almost always. Yeah.
Yeah, I think that viral diseases are by far and away the most common. And seem to help you remember that. It's so powerful to emphasize what pharyngitis really is, and it's a diffuse irritation of the pharynx. This is a theme we'll come to, is bacteria tend not to cause diffuse. And that'll be a really powerful clinical reasoning theme that we'll revisit. But to help you remember that, let's do a little exercise together, Glenn, okay? Now that you're heading to your internal medicine rotation, I'm going to tell you about two completely separate things that will ultimately come back to our conversation. And those two completely separate things are two x-rays. Both patients have respiratory symptoms. And in one patient, their x-ray shows diffuse interstitial infiltrate. The other patient shows a focal right lower lobe consolidation. Which of those two x-rays, right lower lobe consolidation that is focal or diffuse interstitial infiltrate, which of those two patients do you think is more likely to have a bacterial infection? What do you
Um,
think?
Hello everyone. I'll be thinking more to the right lower lobe instead of diffuse.
Exactly right. And if you apply that same analogy to the pharynx, viral diseases can tend to cause widespread symptoms. So much so that one big tip-off to the presence of viral pharyngitis are symptoms far away from the pharynx. And far away can mean systemic myalgias, which is probably a universal feeling in the 21 people in this room. But even sometimes without the whole body myalgias, you're going to get sore throat plus. And that sore throat plus is plus a cough, plus rhinorrhea, plus conjunctivitis, plus preauricular lymphadenopathy. I want you to imagine the X-ray of the upper respiratory system being diffuse interstitial infiltrates. In stark contrast, if you study the center score closely, which helps you predict the presence of bacterial pharyngitis, boom, focal consolidation on the pharynx itself. And see, in most people who are coming in with pharyngitis, as you're probably seeing now in wintertime in Pakistan, everybody has rhinorrhea, cough, that diffuse infiltrate. And so much so that you might fool yourself into thinking that the base rate is different because many of those people don't even come to clinical attention and they just kind of take care of it at home with some warm tea and treatment. But unfortunately, depending on where you practice culturally, and I will tell you, my patients, veterans, have a very low threshold to come in for these symptoms. So even then, the base rate is still by far and away those bread and butter symptoms. So that makes it really hard in real life to do the first and most important thing, which is to ask ourselves, is this person just having the sniffles? Or are they having bacterial pharyngitis? And that's the first and most common sort of tension that Austin articulated. So, Manaswini, I'm really curious. This is going to be really handy no matter what you do. Now that if we filter this whole conversation to that tension point, you're operating in that zone of a very common clinical decision, which is how do I distinguish between viral and bacterial pharyngitis? What is your current knowledge of that space?
If it doesn't improve on within 7 to 14 days,
Yeah.
we would start them on antibiotics and think bacterial. Or if there's exudates like
Mm-hmm.
purulent,
Mm-hmm. Yeah,
probably
good.
then. Or if there's associated inflammation that's too high, yeah.
Yeah, good. Good. Very, very good. Yeah, you hit on a lot of themes, and the goal of this conversation is to have that be anchored in in reality. I will plan to see that we'll talk about this important tension point, and then we'll up the ante and make the patient much sicker and talk about the serious complications that can happen with pharyngitis, which is why I'm so glad that Alex is here because the airway and the lungs are unfortunately a massive vulnerability. So, viral versus bacterial is an age-old dilemma. And I think what we really probably should do is not get so involved in the details first, but ask, why does this distinction matter? Why do we spend so much time and so much healthcare resources trying to figure out if it's viral or bacterial? So, Sneha, what do you think about that question, about the big picture? What is the real difference between the two?
So I would think the most of the viruses,
Yeah,
apart from the influenza infections, would
yeah,
be self-limiting. Yeah, but I would still, maybe even if I'm treating the patient conservatively, I would still ask the
yeah.
patient to come back if the symptoms persist.
Yes.
One is I would think about influenza and whether to test for that. And
Mhm.
secondly, sometimes they end up developing secondary bacterial infections on top of the
Very good.
initial viral infection. This is what I would say. And certain times when it is an elderly patient having a cardiac background, I would
Yeah,
go
very good.
straight away and check for
Very good.
the influenza because I don't want
Yeah,
them to have other complications.
very good. Excellent. That's really, really powerful articulation. So you're talking about a subset of viruses that have profound implications. Realistically speaking, the implications are all related not to the virus itself, but rather to the vulnerability of the host. So if I were to seek care, thankfully, it's true now in my third decade of life, it may not be true later on. But if I were to get pharyngitis and I was confident that it was viral based on things we'll talk about, I wouldn't need to know if I have COVID, influenza, because there is nothing that anyone can do about my risk of complications. I could be one of those very unlucky young people who has horrible complications, but there is no data to suggest that early intervention with antivirals has any preventative effect on me. But it might not be true for older and more vulnerable people where the early treatment of antiviral therapy for either COVID or influenza has potentially some therapeutic benefit for prevention of complications. You're, of course, left in no doubt as to do diagnostic testing in people who are sick. There's no doubt about that. But if you're in the realm of prevention of dysfunction, um, it's really about the vulnerability. And I'm not here to disappoint you, but to tell you that if I were in control of healthcare, I would not prescribe a single dose of oseltamivir or a single dose of Paxlovid for preventative complications. I think when patients are sick and sick enough to be hospitalized, every effort should be made to try to reverse their course, including theoretical ones, which we do all the time. Um, but when you scrutinize the value of data of oseltamivir and Paxlovid for prevention of complications in high-risk patients, um, the cumulative cost of doing so on a mass population level is not worth the return on investment. It sounds very crass to say that when there's an individual in front of you who hypothetically might benefit from a medication, and I break to that emotional valence and concern all the time. The patient tells me, "Hey, I really want it." I'm like, "Oh my God, please have seven, no problem." But if I'm in charge of the healthcare system and I'm trying to keep everybody's health, not my own personal patients who are right there making eye contact with me, I wouldn't do it. Um, and as Austin just mentioned, it's not just a cost thing, it's the personal complications of the side effects of these medications are profound, particularly oseltamivir in older people. So that was a long way to say, like, why do we care? And of course, if somebody is sick, we care. If somebody could get sick, we might care. But if somebody's just having a sore throat and nothing else, you might ask yourself, what am I really trying to accomplish here? And that question extends to bacterial pharyngitis as well, believe it or not. So, Zachariah, I'm curious if you've been exposed to this question before about what the return on investment is for antibiotics for bacterial pharyngitis. What are you getting in return for that amoxicillin?
Yeah, I think I haven't seen actually much strep throat in South Africa, but
Hmm.
I think we more see the complications later on as we have a lot of rheumatic heart disease. I think you're trying to
Yes. Yeah.
prevent a rheumatic fever in certain populations where there's a high
Yeah.
test probability
Totally.
of it being Streptococcus. And then I think, if I remember correctly, post-streptococcal glomerulonephritis is more likely to be from a skin disease, but you sometimes can see it with
Yes.
pharyngitis as well.
Yeah, very good. So you're trying to prevent these complications related to these non-suppurative complications related to strep. And they're all fairly interesting, fascinating immunological phenomena, some of which we actually saw in VMR, where a patient had group A strep pharyngitis complicated by IgA vasculitis on Thursday. Sorry for the spoiler. Um, but maybe we can go back to you, Austin. I'm really curious when you zoom out and you think of it at the population level. I'm curious what your take is on the return on investment of antibiotics for bacterial pharyngitis at the population level.
Yeah, I think the population level, I think it's just so this is such a fascinating question, generally speaking, because
Yeah.
if you think about I think the one I see in clinic the most is actually statins and what the investment is on that for primary prevention.
Mm,
And the primary prevention benefit of statins is abysmal.
yeah,
But if you're the individual person, if you
totally.
are a population, you'd be like, wow, I can prevent on a billion scale, like hundreds of thousands to millions of heart attacks and strokes. That's very meaningful from a system standpoint. But if you're a person that I can reduce your risk of having a stroke or taking a statin for at least 10 years of your lifetime by 1 to 2% at most, is that meaningful for the individual person? Depends who you ask. I'd say for most people, 98% is almost as good as 100%. So it's like not really there. But going back to your main question, I'd say like probably the return on investment for antibiotics for bacterial
Yeah,
pharyngitis in particular is pretty low, as most people
yeah,
will get better on their own without
yeah,
significant time. So really, if you look at the data, they'll say, hey, you can improve basically what you're impacting is the time to improvement by
Right.
maybe a day, a couple days. Like in the vast majority of people, that's what you're going to see. So I think from a population perspective, you can get people back to work quicker, into in the environment quicker, taking care of their kids quicker, et cetera. So like there's that aspect. But as far as like disease prevention, like how much post-strep glomerulonephritis, as Zachariah was saying, am I going to prevent? How much Lemierre's am I going to prevent? How much IgA am I going to prevent? Like the rheumatic fever, like honestly, the yield is so low that you question why you do it oftentimes. Now, this is the thing, it's like it's all an odds game because the morbidity of these things is really high. So if you're the unfortunate person that got it, then you'd ask yourself, why wouldn't I take antibiotics even if it didn't anything, if it prevented what happened? And this is the odds game that you'll see if you ever have children, because when you go to the doctor and they clearly have a viral illness because it's spread through the whole house, and I've gotten it, and my wife's gotten it, everyone's gotten it, every single time you go, you get antibiotics every single time. And you ask why? Like, why are we doing this? Doesn't make sense. But it's because not only is there a hearing component to this, like cumulative infection and the risk of not treating bacterial infection increases the potential risk of hearing loss and then subsequent like cognitive development and everything. So they take that very seriously, but also the risk of these complications, they feel like the benefit of antibiotics is more than the risk. But as soon as you reach adulthood, like the balance shifts so much, even though statistically speaking, probably those two spaces are not that much different. So I think you can argue about the like the burden on the system and the population about like preventing chronic illnesses from forming and having to deal with the system. But from a practical standpoint, these are all pretty uncommon complications. So even if you don't get antibiotics, most people are going to live, and that's proven by the fact that antibiotics have only been around for 100 some like years, and humans have been around for many thousands of years, and we're living for not forever, but for a long enough time that we were able to reproduce, etc. So the impact of these is like relatively low, I would say. But I'm not sure if that was the point of your reflection or
No,
not.
I think that's exactly the point. I think that the simple principle is that an infection at the surface rarely requires systemic treatment. And the return on investment for an infection that is at the body's surface rarely needs pills that have 100% bioavailability. And I think that's a very difficult thing to articulate because we know that actually antibiotics for bacterial pharyngitis does reduce the risk of complications. It reduces the duration of the illness. It reduces the risk of both the suppurative and non-suppurative complications. So why the heck would you not do it? And the short answer is that the base rate of those complications competes with the predictable complications of antibiotic therapy, including resistance, C. diff, so on and so forth. So the return on investment is of question. Now, the return on investment is not of question for the individual before you, because the individual before you couldn't care less about the risk of antibiotic resistance to the people halfway across the world unless they are medically educated or have reason to invest in it. They want to feel better 24 hours sooner so they can go feed their family, right? Uh, and so I just wanted to emphasize that the point of this entire conversation with pharyngitis is that you really shouldn't spend too much time. It doesn't matter. That, most of the time it's a sore throat. It's not an ulcer or a mass, but you should take a look, make sure it's not a big ulcer or a big mass. Uh, you're going to try to figure out, is this viral? Is this bacterial? And yeah, sure, you can try to spend some time doing that. The short answer of that is the more and more focal it is, the more and more the throat hurts, the more and more there is no cough, there is no rhinorrhea, the more and more isolated it is, the more and more likely it is to be bacterial. If you miss bacterial or if you don't give somebody who looks fine Paxlovid or Oseltamivir, they're going to be just fine. That's fine. So what's the thing? What's the real issue with pharyngitis? Is don't sweat it. Don't spend too much time, too much resources. Try to be very patient-centered about it. In terms of exactly how I practice, I will tell you that I ask myself not what is the Centaur score, because I think the Centaur score is a little bit flawed. But the Centaur score is a great tool for you to begin your understanding of how to distinguish between viral and bacterial pharyngitis. The premise is exactly what we talked about. Bacterial pharyngitis have focal consolidation, viral pharyngitis diffuse infiltrates. So I ask myself, what is the center of gravity of this patient's complaint? And if it's just pharyngitis alone, the probability of bacterial pharyngitis becomes reasonably high. And I just do that simple calculus. If you look at the Centaur score tells you that exudates lymphadenopathy, and a fever are predictive of bacterial pharyngitis. In my experience, that doesn't pan out. And now, 10 years out, I have not had enough ends to have my own mental study, which I haven't done rigorously. But I'd say the vast majority of patients with COVID and influenza have a fever. The number of exudates I see in viral infections is through the roof, and the amount of cervical lymphadenopathy that I see in viral infections is also through the roof. Um, and so, what do I really use? I use the absence of a cough as a very powerful feature. I have never had pharyngitis that was viral without a cough personally, ever. And I never, 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 never have ever prescribed antibiotics to anybody who was coughing. And I view that to be illustrative of the tension of the diffuseness of the syndrome of viral disease, often always causing airway irritation. So here's my practice pattern. If I'm convinced that they have a sore throat and a sore throat only, I pay attention. If they have sore throat plus other things, I'll let them decide if they want testing for viruses or not, but I will not offer any treatment. Because if they just have a sore throat, their ability to benefit from the treatment is very minimal. But if their sore throat is really bothering them, they have nothing else going on, I think the possibility of a bacterial pharyngitis is plausible. And then I owe it to them to have them make a decision about whether they want antibiotics or not. It's not for me to make. And if they're very conscious about, just like Austin might be, about the consequences to his body for C. diff risk and to the world, then yeah, don't take it. But it's not my decision to make. So here's what I do. If the story seems very focused on the pharynx, I offer viral testing, and the viral testing for COVID and influenza comes back in 30 minutes. If that's positive, the probability of a dual diagnosis is super low. If that's negative, they're getting antibiotics if they want it. Now, you may be perplexed and say, well, wait, why don't you do bacterial testing? And the answer is yes, absolutely. We do bacterial testing. We send for a group A strep antigen, which comes back in 30 minutes. And then we send for a throat culture, which comes back in 48 to 72 hours. But why does everyone with a pharyngitis that is focused on the pharynx without distant symptoms, with negative viral testing, why do they potentially benefit from antibiotics? And this has to do with two key things. One, the sensitivity of the antigen test for strep, or specifically group A strep, and the presence of other non-group A strep causes of bacterial pharyngitis. So if we shed for a moment the concerns for the populace about antibiotics, and if all we care about is the safety and health of the patient individually before us, this is crucial to get right. Because there is, as a result of increasing vigilance of antibiotic prescribing, an increase in the rate of suppurative complications for young, otherwise healthy people with non-group A strep pharyngitis. I'm going to say that one more time. The main issue with pharyngitis, the main issue, is overthinking it. When should you pay attention? When the story focuses on the pharynx alone, without a cough, without rhinorrhea, without myalgias, and the throat hurts like heck. And if any of you have experienced it, you probably had strep throat, as have I. We know in those people that there is a number of young, otherwise healthy people who are dying from Lemire's disease because they did not get antibiotics up front. Now, this is classic CP solvers, right? We're trying to be mindful of the base rate, not to overthink it, but we also at the same time can't be lazy and not ask ourselves, who do we obsess about? And I obsess about the people who have really bad pharyngitis, no distant symptoms, and I don't park my bus at group A strep antigen. Why? The antigen test is only 70 to 80% sensitive. It, with culture being the gold standard, it misses 20% of what then turns out to be group A strep on culture. And it's not the only bug. There are so many other group B, group C, group D, group G Fusobacterium, so many other causes of pharyngitis. So here's what I do. If the viral testing is negative and the patient just has a sore throat, has nothing else going on, think of that as a consolidation. That is a bacterial pharyngitis until proven otherwise. Again, you don't care about the population, you care about the patient in front of you. And if they are pro antibiotics because they want to reduce their risk of complications, we can do that. Do not anchor your thinking on the test that will come back in 30 minutes, the group A strep antigen test. It has two holes in it. One, 20% group A strep will not be caught on the antigen, will be caught on the culture. And two, there are so many other causes of bacterial pharyngitis. So those patients get amoxicillin from me every time. Now, I won't continue the amoxicillin forever. I'll stop it at 48 hours if their cultures are negative. Okay, I'm going to pull up a picture so you guys can see this with more clarity now that we've talked about it. But as I do that, please unmute, ask your questions before we lean on Alex and get really spicy.
Yeah, I wanted to say, and perhaps when you say viral testing, we're actually also including an HIV test. But the one thing I wanted to say,
Yeah. That's an important reflection, Zachariah. If you did an HIV test in everybody who had a sore throat, you would be doing the world a massive service, but the lab would hate you because the base rate of pharyngitis is so high. So we will talk about true no miss viruses. Sarah mentioned one already, measles. I believe mononucleosis, EBV, CMV, HIV are no miss for subtle reasons, splenic rupture, so on and so forth. But I will just plant the seed that it would be pretty unusual for a patient with acute HIV to just have pharyngitis alone. And as part of what we're going to talk about next is uh, right now we're emphasizing the conversation about just sore throat full stop. Those are the patient populations you need to pay attention to. But those are not the only ones. And you're already planting the seed for, wait, what about gonorrhea? What about chlamydia? What about mono? What about HIV? Yeah, I would say though that if you do your job well and the center of gravity is truly on the pharynx, I think, gosh, send an HIV test on anyone who shows up. But if you only had one test to use, you probably hold off on that specific individual. Other questions or reflection? Okay, let me show you this picture, and I'm gonna have you guys stare at it for a sec while I go use the restroom real quick. All right, nature calls sometimes. So, questions, reflections? Yes, Krishna, go for it.
So I wanted to ask you, if a patient comes to you to the clinic and says that they have sore throat and have no cough or some minimal systemic symptoms, I'm not sure what the usual turnaround time for a viral PCR is,
Mhm.
but Usually, like you can do a rat test just while the patient is sitting in the
Yeah,
clinic, and in 30 minutes you can give them the result. So
correct.
if that is the case, why not just do the rat test on those patients before we do the viral PCR?
Oh, by rat test, sorry, I thought viral PCR was by rat test. Tell me what you mean by that.
The strep test. I'm not sure what
Yeah,
the
right.
turnaround time for the viral PCR is.
Yeah, the viral PCR turnaround time is about 30 minutes. And I think the premise of that is that, well, it may be delayed, but at least in my, this is sort of what I do every day. If you have a plausible explanation, a plausible virus, you don't need to think it further. The premise being that a dual diagnosis for pharyngitis is exceptionally rare. And that if you have a reason not to prescribe antibiotics, then you probably shouldn't. That makes sense?
And are the
Yeah.
like for the step testing kits,
Yes.
we can get the kit in the clinic itself, and we can do the test in the clinic itself.
Yes.
Can we do the viral PCR in the clinic
Yes.
as well?
Yes.
Or okay.
Yeah, I think it's I think PCR testing, point of care PCR testing is increasingly available. In my emergency room, it is, but I think it probably is not a universal feature. So I'll tell you what happens in my like literally when somebody comes in and they have pharyngitis and they're fine. Um, uh, we do the testing even before they leave the triage room. The nurses have stockpiled viral PCR testing in the triage room, and then like 3 or 4 strep throat tests, which tells you what usually happens, like 100 viral PCR tests and like 3 strep throat tests. Most people they have diffuse symptoms, but they want to know what they have, even though it doesn't really matter. So we swab them for customer service. Um, as my office mate likes to say. And for the people who I want them to is when it's just their throat, and I'm already starting to think about giving them antibiotics. But if I find it to be an unusual presentation of a virus, I say, hey, you have a virus, you don't need antibiotics. But if I can't tell them that they don't have a virus, then I owe it to them to offer them antibiotics, at least unless they are more globally conscious and really love their neighbor more than they love themselves, which is not a small number of people.
And these viral test
Mhm.
PCR kits you're talking about, are they multiplex PCR, so they test for multiple viruses at the same time?
Yes, correct. 3 viruses at the same time is the one we use. It's influenza, um, RSV, and COVID.
So if we were in a like a resource limiting condition,
Hmm.
which virus would you prioritize in terms of checking?
Yeah, if I was in a resource limited situation, I would not do any testing and prescribe antibiotics to people who have focal. I would just let it be. Yeah, and if I were in an extreme resource limited setting where I had no antibiotics, I would give the patient a hug and tell them they're probably going to be okay. Yeah.
All right. Thank you,
Yeah.
Dr. Rabih.
Yeah, yeah, for sure. But that's not yeah, the same turn. Okay. Alex, this doesn't go well sometimes, very rarely, especially in the realm of suppurative complications. So I'm really curious if you bumped into somebody with pharyngitis who then got into trouble from a suppurative perspective.
Yeah, we've had speaking of acute pharyngitis, sorry for my voice, everybody. The we have a
Wow, it's like a plant.
we definitely see Lemire syndrome in young patients in the hospital. And I've had maybe 1 or 2 cases I can point to of a patient with a who evolved a retropharyngeal or peritonsillar abscess. I guess thinking of somebody now, I'm not following them directly, but just overhearing the conversation from my colleagues who are on the pulmonary consult service I know there's somebody who is on that service now who is young, is about my age, who had pharyngitis that she just sort of brushed to the side maybe 2 or 3 weeks ago, and then basically presented with a P, and was found to and the thought is that she has Lemire syndrome. And the interestingly enough, she tested positive for group A strep and not for the, I guess, more classic Fusobacterium necrophyllum.
Fascinating. Yeah, I think that if you're seeing how devastating the effects of pharyngitis can be, and they all squarely end up in Alex's shoes. The simple way I think about them is that they either affect, well, I think about them in terms of what they can do locally. Um, you can go backwards And that's in fact the most common suppurative complication that happens. So you get a peritonsillar abscess. And if you go real backwards, you go behind the pharynx into the retropharyngeal, which is horrible. It's horrible because it exists in what's called the danger zone, where there's a direct connection between the mediastinum and the neck. So if you're thinking about how these two structures are connected, there's a lot of barriers for things to ascend up this way. The two ways that things can go from here to here without having a fascial plane cross is the skin. So you'll see patients who have subcutaneous crepitus or air right under their skin. It'll go right up to their neck. And the other way is deeper within in what's called the danger zone, where the retropharynx communicates with the mediastinum directly with no barriers whatsoever. So the worst place to have an abscess is right behind the pharynx. It goes straight down. Uh, excuse me. So backwards, peritonsillar and retropharyngeal. You can go outwards into the veins and cause septic thrombophlebitis. And when you have a thrombus here, it can spread to the lungs very quickly. And they can go down. And when it goes down, it causes Ludwig's angina. And that is a devastating consequence of suppurative complications. Most of the time, suppurative complications enamor us because they show us how the bacteria macroscopically move backwards, laterally, downwards. But sometimes the suppurative complications develop in the thorax without leaving a clear track of how it got there. And you can think of it as like a few bacteria escape and they actually go into the thorax. And so patients can develop empyemas, patients can develop lung abscesses, not by leaving a trail, but by a few bacteria escaping and taking up shop in the respiratory apparatus. There are, of course, a whole slew of non-suppurative complications, which are very cool, very interesting. We already touched on a little bit of them. Those are very, yeah, I mean, I think the thing I'd say about them is they illustrate the conversation that is happening between pharynx and systemic disease. And that is a somewhat friction-filled transition to what Zachary brought up. Pharyngitis with systemic features. So, because we only have 10 minutes, I'm flying through this, but to make sure we have our benchmarks, somebody who just has pharyngitis, don't worry too much. Don't go crazy. It doesn't matter. If you're in a resource-limited setting, as Krishna illustrated, sometimes a hug is all you need. But if you have some tools, use them, especially if somebody doesn't have the adjacent features of a cold. Colds don't cause a focal consolidation. They cause diffuse infiltrates. So you really want to use your testing. Somebody's like, sore throat, sore throat, sore throat. Why? If you have a positive viral test, great. You don't have to worry. But if you have a negative one, you have the potential to reduce suppurative and non-suppurative complications. Suppurative, back, down, outward, or microscopic seeding to the respiratory tract. The non-suppurative, so many, all really cool. Post-strep strep nephritis, reactive arthritis, so many of them. You can't keep track of them. You just have to know that when somebody comes in with a fancy autoimmune vibe, you have to trace it back to their throat. But what if somebody has pharyngitis and, unlike the base rate, they have systemic features? And I think to keep it brief, whenever the pharynx is involved in a systemic illness, you really have to think a widespread virus. And actually, it's just an extension of what we are already talking about. We are already talking about how respiratory viruses have diffuse interstitial infiltrates. And sometimes the interstitial infiltrates can be mega diffuse. And the most common reason that happens is you have COVID or the flu, and you test for those. But the more and more prominently systemic the illness is, and the smaller and smaller the pharyngitis is in the context of the systemic illness, the more you have to ask yourself, is this a primary pharyngitis or a secondary pharyngitis? And these are the beautiful laws of proportionality in medicine where you are studying how much of the pharynx and how much of the systemic illness are in relation to each other. And if I have somebody who has a systemic disease featuring pharyngitis, gosh, I think of the two M's, right away. Measles, and then mononucleosis syndromes. The mononucleosis syndromes are EBV, HIV, and CMV. And those are patients for whom, in addition to doing all this local stuff, send off blood-based testing. So the needle comes out, not the swab. The needle comes out when you're like, oh, exhausted, I'm really, really tired. Now, I want to caveat that by saying I'm really, really tired, exhausted, but you get the sense that this throat is really the dominant part. You might just stop with a COVID and flu swab. But if you're like, I'm not eating, I'm not drinking, I'm nauseous, I'm vomiting, my spleen hurts, I have a rash, I have diffuse lymphadenopathy, that's when the two M's really, really come to. The only thing that is really, really important to pay attention to in the background of the patient is sexual activity. So let me paint this whole story for you all from beginning to end, and then we will stop. When somebody comes in and they have pharyngitis, I try to figure out to some degree who they are, and who they are is really a question of their immune status, if they're a vulnerable host, if there's somebody who I might reluctantly offer Paxlovid to or whatnot, and then their sexual activity. And I need to know those two things. Either they're evident in the chart or they're not. Those are the things I try to establish in terms of context and who this person is. When we're focusing on the foreground, you're trying to understand how prominent is the pharyngitis. And the middle ground is the most common. What do I mean by that? A little bit of pharyngitis with a lot of local action. Most common. If it's just pharyngitis, a lot of it, I wake up. If it's a little bit of pharyngitis with a lot of systemic features, I wake up. Otherwise, I'm like, oh, why are you here? I can do nothing for you. This is an utter waste of your time. I'm so sorry. That's it. What are the bad things that can happen to people? Back, out, down, and lungs. Okay? Background, two things: immune status, sexual activity. Foreground, pharyngitis with a little local, most common. Pharyngitis alone, bacteria. Pharyngitis with a lot of systemic symptoms, the two M's, mononucleosis and measles. And I'll send you a picture of that, and I'll stop there to see what questions or reflections you all have. Here, since we have 7 minutes, why don't we do this? We'll do a 5-minute breakout room to percolate their thoughts, ask questions of each other, clarify some friction points, and then we'll come back as a large group to see if there's any overwhelming themes that remain. Okay? All right. See you all in a few minutes.